Welcome to the New Books Network.
Welcome to the New Books Network. I'm Stephen Pimpare, host of the Public Policy Channel, and we are joined today by Seth Berkowitz, who is the author of Equal Care, Health Equity, Social Democracy, and the Egalitarian State, new out from Johns Hopkins University Press. Seth, welcome. Thank you for joining us today.
Thanks so much for having me. I'm very delighted to be here.
So why don't we start off, if we can, by asking you to tell folks a little bit about who you are and what you do and what brought you to this particular project.
Sure. So I'm a primary doctor, a primary care doctor. I see outpatient adult general medicine patients in my clinical work. And I'm also a health researcher. I study how things like food insecurity or housing instability impact health and whether there are interventions that we can do either within the healthcare system or more in terms of public policy to address it. And what really sort of led me to think about the book was, the rise of emphasis in health equity work over, say the last 3 or 4 years, particularly I think since the COVID pandemic really turned a lot of national attention to the important problem that health inequity presents in the U.S. But also, my growing recognition that as important as the work that's going on within the healthcare system is, what are really driving a lot of the problems that we see are issues that are better addressed through public policy. And so if we wanted to kind of take seriously take seriously health equity, what would our public policy need to look like in order to do that?
Perfect. So let me start here. I think it's fair to say that your typical health policy book they all look sort of similar, right? It'll begin with, say, a diagnosis of the failures of the US system, often with attention to those disparities across various groups that you made reference to, might compare the United States to other countries and inevitably find us wanting, offer then some proposed policy changes to remedy those failures, then maybe consider the political obstacles to enacting those kinds of changes, and then even more rarely, sort of walk us through strategies to overcome those failures. That, I think, is fair to say, is not the framework of your book and the way in which you approach the question. So why don't we start there, right? Lay out for listeners, if you will, how you've organized your thinking and your discussion and why you're taking the approach that you do.
Yeah, no, that's right. I think you hit the nail on the head there. So, I tried very hard in this book not to just focus on the healthcare system or, things that doctors would do or things like that, because I don't think that's really at the root of the issue. I think work that we can do within the healthcare system is important, and certainly I don't disagree with any of the work that that does find our healthcare system lacking in international comparison. But I did take a different tact. The three elements that I thought were really key for thinking about, how to address these problems were, one, having sort of a normative justification for the project of health equity. So, health equity is a normative term. It's talking about values. It's talking about equality. And so I think we need to be very clear on what we mean by that. Two, I think there needs to be an empirical grounding, meaning that we need to understand how social circumstances come to harm health, and when different people experience different social circumstances, that's how we get health equity. So some people are harmed by our social circumstances, and others are helped by them to be healthier. And then third, I think we need sort of a technical understanding of, all right, we know what we should aim for in the normative piece. We know what are the social circumstances that are health promoting, or conversely, the ones that are harmful. Technically, how do we produce that in a public policy sense? What can we learn from economics and sociology and public administration and taxes and public finance and all these different fields that you need to put together a system of public policies to really create the conditions in which everyone can be healthy. And so those are sort of the three key sections of the book, building on each other and showing how those pieces are interrelated.
Terrific. So for selfish purposes, most of my interest winds up being in bucket three, but I want
Sure.
to pay some attention to those first two buckets. Because in some ways, sort of, I'm reading this as, you know, a public admin, public policy guy, and wondering if you were trained as a political theorist, right? Because that first section in particular, right, when you talk about normative justifications for why we focus on equity, you mean it. So talk a little bit about how that thinking informs how you approach the topic and why you think we should do more of that. Maybe us sort of policy folks, maybe whether you think we should be better grounded in that normative kind of thinking.
Yeah, so I think that's a great question. And to sort of sum up the answer, I think the reason that normative grounding is very helpful is sort of summed up by the phrase, the devil is in the details. And what I mean by that is, I think abstractly, really a lot of people, and even in a very polarized environment in the US, really a lot of people across the political spectrum accept abstractly the value of equality, that we in some sense think, all right, everybody should be equal or is equal, and that kind of thing. But it turns out that there are a lot of different things you can mean by equal when you say it that way, and that I think gets to the root of our disagreements. And so the first the chapters of the book, chapters 3 and 4 in particular, that kind of get into this, really try to walk through what are different conceptions of equality, because the policies that you might put in place to try to produce that equality really will vary based on what your version of equality that you're thinking of, that you think is important and normatively justified, is. And so I try to walk through different ways you may do this, a sort of libertarian or laissez-faire type of equality, where equality is sort of getting out of the leaving everybody to fend to themselves, and not being, quote unquote, interfered with, but otherwise sort of left to your own devices in an equal way, or a utilitarian type of equality where everyone, their utility all sort of counts, but it then gets added together, and we pick policies that, theoretically at least, maximize that utility or something like that. I talk about arguments why I don't think those are the right visions of equality to pursue, and I settle on something that philosophers, and I'm not a trained philosopher or anything like that, but just from reading that I think philosophers refer to as relational equality, meaning that the equality that I think we really care about is sort of equality of status or social standing, that everyone sort of has a say in the issues and decisions that affect them. And this winds up being very, I think, intertwined with the idea of democracy. In fact, I think a sense of relational equality is what justifies, democracy as a governmental system where everyone again kind of has a say in that. And so I do spend the time in the book there, because the policies that we wind up talking about later, I think really are justified in reference to this particular vision of equality. And if you didn't have that vision, you might excuse me, look for other types of policies. So it really is the grounding of the policies that we talk about later in the book.
So talk to us a little bit, if you would, about that second section that in the book is referred to as developing mechanistic knowledge, and what you just referred to as the social circumstances of health promotion. How does that then connect us to that normative framework? And then we'll move on to talking about sort of policy design issues.
Yeah, so the second part of the book is probably the most medical, the most doctory, the most epidemiological part of the book, and the goal in that chapter is to, or actually in two chapters there, chapters 5 and 6, is to make a connection between the normative piece, so what we think we should want in terms of that relational equality, and what actually leads to health in the real world, because the overall idea here is that by pursuing this normative vision will produce better health for everyone, and lead to health equity in that sense. And so part of that is an empirical claim. Why is it that the conditions that would be produced by the policies I'm advocating for would lead to health, or conversely, why is it that our in my view substandard public policy that we have currently, why is that producing poor health? And so the goal in those sections is to review the empirical evidence around that, to talk about the pathways and mechanisms that go from inequality of social standing to poor health. And, that's where we talk about common things like income distribution, like exposure to environmental conditions, racism and systems of oppression. All of these things, and get from how deviations from the vision of equality that we talked about in the first section produce the poor health outcomes that we're concerned about addressing with the policies that we'll talk about in the third section.
Terrific. So as you just gestured toward, the book is ostensibly about health policy, but you are, of course, looking much more broadly at a whole range of things that a welfare state can and does not do, and then land on a very particular vision of the kind of welfare state that you think most likely moves us toward that normative vision. So very briefly, what the heck is a welfare state in your way of thinking? And why do you think a social democratic one is the way in which we best achieve the goals that you've articulated for us?
Yeah, no, that's totally right. And I think a really important principle that sort of guided me is that health policy, i.e., public policy that affects health, is much broader than health care policy, i.e., public policy that talks about how we finance the care you get from a doctor, those kind of things. And what that and in particular, I think where health policy expands from healthcare policy is all of these things that what I call the welfare state talks about. So you can think of the welfare state broadly as being about the policies in a country that have to deal with how people meet, kind of their basic needs: food, housing, transportation, education, healthcare, income distribution, all of these things. And it's important to recognize that, sort of all countries have policies that affect these things. Sometimes that involves setting up public programs and being sort of more actively involved on the public sector side. In that, sometimes it involves saying, well, we're going to set up laws and regulations and courts and law enforcement and things like that, but otherwise let private parties sort of use those to sort things out. But there's always sort of a decision being made that we're going to handle these things in one way or another, because these are our basic needs, right? And so, if we all need health care, the options are, there's sort of a public approach to providing access to healthcare, or, we set up situations that people can pursue that privately. So you're not really not having government involvement in a healthcare system. You're just sort of choosing which way to do it. So that the point is that, all countries effectively have policy that touches on these welfare topics. And so I sort of, think of the welfare state as being the set of policies in any country that, deals with these kind of basic needs. Again, food, housing, transportation, education, healthcare, those kinds of things. But there are different ways you can do that, and sort of two key ways, or sort of two key flavors or families of welfare states are what you might call a residualist welfare state and a more universalist or social democratic welfare state. The residualist welfare state gets its name from the idea that the government is only supposed to step in when there are leftover residual needs that could not be met in the quote unquote regular way through jobs in the private sector or through family assistance or those kind of things. So this is sort of the safety net view that, yeah, if there are no other options, we'll kind of step in and do something. But we don't in general want people to be doing this as sort of a regular way. The universalist welfare state views its policies and programs as sort of the first line approach. It's just the normal everyday way that everybody gets their need in a particular category met. Everybody uses this healthcare system or this education system and stuff like that. these are sort of ideal types. And so there's probably no country in which it's all one way or another. And even the US, I think we have a mix of these things. So the US overall, when taken together, is probably much more of a residualist welfare state. But there are areas of the US welfare state that could be considered universalist. So Medicare, the health insurance policy for older adults, amongst others, is fairly universalistic. If you're 65, just sort of the primary regular way that most people 65 and older get health insurance in the U.S. is through Medicare. That's not a safety net. It's not that you only get Medicare if you can't do something else. That's the regular thing. The public school system is sort of our primary regular way of basic education. There are private schools in the U.S., but I think something like 90 to 95% of people or children are educated in the public education system, and that's just sort of the regular way that's done. Not that there isn't variation across school districts and all those things, but that's sort of the regular way. It's not a safety net public education that you only use when you can't get into private education. On the other hand, a lot of our other policies are sort of more residualist or safety net in flavor. So Medicaid, health insurance is sort of the residualist backup. If you can't get insurance through work, if you can't buy it on the private market after the ACA, then you can qualify for Medicaid or something like that. SNAP, the Supplemental Nutrition Assistance Program, or food stamps, is sort of a residualist income support program. If you're going to go hungry, and again, you can't earn the money that you need through a job or something like that, then we've got this sort of residualist, means-tested approach to doing it. Overall, I think that more universalistic or social democratic type welfare states are more likely to produce the kinds of health outcomes we want for two key reasons. One is that I think they embody the kind of normative vision of equality that we want. When you have programs that are just for everybody to use, the rich and poor alike, they sort of embody the view that everyone is being treated equally. There's sort of this. There's a British sociologist from the middle 20th century, T.H. Marshall, who talked about residualist programs as not really being universalist programs as sort of being rights of citizens. So in Britain, you have the right to the NHS, or in the US, you have the right to Medicare. But residualist programs are sort of alternatives to the rights of citizenship. So instead of being able to do things the regular way, the way that everyone else does, you have to use this kind of second class program or something like that to meet your needs. And so I think the universalist welfare state sort of embodies this idea of equality and works against social stratification. So that's one piece. The other piece is just administratively, and I spend a lot of time talking about why I think this is the case. Universalist programs are just easier to run and easier to use because you're not putting a lot of effort into determining, well, is someone truly deserving of this? Do they really need it? And so people don't have to spend a lot of time proving their income eligibility, reproving it, proving there's not been a change in their circumstances that doesn't make them eligible, going through an onerous sign-up process, all this stuff. Some states, to get SNAP, you have to be fingerprinted, you have to have an interview. I mean, all these things where it's like, it really reduces the number of people who get these benefits that they're entitled to. Whereas for universalistic benefits, virtually everyone who's eligible for Medicare signs up for it. Virtually everybody who's eligible for Social Security, old age, and survivor's insurance, the sort of typical Social Security checks, gets them, because these are universalist programs that are made easy to run. And so just the programs themselves reach people, and people actually get their benefits. So that's the other key reason I think that universalist programs are more likely to produce the health outcomes we want than the residualist programs.
And you know this better than I do as a physician, but when we talk specifically about healthcare, right, the sooner you can diagnose someone and begin treatment, the more effective that intervention is likely to be, and the cheaper it's likely to be in the long run, right? Which is part of why those universalist systems wind up providing care to more people and yet doing it more cheaply nonetheless, correct?
That's exactly right. I think being able to sort of nip things in the bud, so to speak, is really important. And I think the other piece of that is there's this sort of double whammy element where there's one vision in some schools of thought within economics and things like that that say, well, if you target programs, if you make them really hard to get into, that's actually going to select for the people who really need it because they're the only ones who are going to put themselves through the
The
burden
ones
of
who
doing
really
it.
have serious
Right.
cancer in
But
this,
in
right?
fact, we
It's
know it
like,
works.
yeah.
Right. And in fact, we know it works exactly the opposite. The people who really need it are often least able to navigate. And so, where you could be getting the biggest bang for the buck, where you could be putting treatments in that produce the most benefits, they're sort of selected out by the administrative burdens of the program. And so, I think you really wind up shooting yourself in the foot in a lot of ways by not being able to get everybody enrolled, access it early, get people the treatments that they need to produce these benefits.
So, as you have pointed out, this approach is not necessarily foreign to the United States, right? We have Medicare, we have the Veterans Administration, which is arguably
Right.
right straight on socialist program, right? I
Right.
mean, the government runs the whole thing, and it has enormously high rates of satisfaction and success. But that said, that is, I think, not how most of the system functions. So, talk a little bit about how you think we design programs that not only deliver more effective health outcomes to more people, but also recognize the obstacles that we're going to confront in the political and policymaking systems.
Yeah, no, I think it's a real challenge, and I mean, I will say, I think a very fair criticism that you could make of the book is that a lot of it is about what we should want and how to do it if we were in power to enact it, but it's not a lot about the organizing and other things that would be necessary to actually put people with these views in power to do that. Part of that is because I think that's not my area of expertise.
Those
I'm
are
not
other books.
yeah,
Yeah.
exactly. I'm not a political organizer and those kind of things. But I do think, this idea of what we should want in a detailed sense, I do think is kind of really important because, again, I do think there's kind of broad agreement abstractly. We want equality, we want things that work for everyone, and things like that. But once you start getting confronted with sort of real world realities, well, how do you actually operate a program like that? What are the ins and outs of it? What are the trade offs that you have to make, and what kind of thing? If you're not very clear on what the underlying goal is, then it can be difficult to know exactly what to pursue. And so, one hope that I had for the book was it tries to be very detailed on clear on what I think we should want, so that if you're in the position where you can start thinking about designing policies and enacting them and those kinds of things, you can do it. And I can give it sort of a real world example. And I think this often comes up when you're talking about different versions of policies that seem on one level similar, but have some differences in them. So in 2021, we had the expanded child tax credit. Which provided income to basically all families with children in the U.S. We have had child tax credits for a long time in the U.S. We had them before 2021, and we went back to a version after the 2021 expansion expired. And a lot of them seem similar. The structure is fairly similar. It's a certain dollar amount per child, often on the order of about $3,600 right now. Administered through the tax code and those kind of things. But there was a big difference that in the 2021 version was that it didn't have a minimum income limit to get it. Most of the
Yep.
time we've had these tax credits, you have to have a minimum income. It's not huge. It's a couple $1,000s usually, but it is a minimum income. And what that means is that the poorest families, those without taxable income or sort of what we call ordinary income, don't receive any benefit whatsoever.
Yeah.
Now,
Those most in need are
exactly.
ineligible.
Now, if you have a benefit that's trying to, make it so that kids don't experience food insecurity or those kinds of things, not targeting the people without income is sort of a big hole in your policy. But for a lot of policy debate, we talk about child tax credit and there's broad support for that. But this is an example of how slightly different versions of the child tax credit, whether you set the income floor at zero or set it at $2,000, can actually make a really big difference. And if you're not kind of paying attention to what you're trying to do with these things, you can sort of miss that. And so I guess this is a long way of saying that one of the things I hope from that readers might get out of the book is that you can look at some of these things where you say, all right, yeah, a couple different folks are proposing a child tax credit. I want to help children. I don't think children should grow up in poverty. But without really getting into the nitty gritty, you might not realize how it would actually play out. And if one, has, say, all right, well, we'll have it for everyone, and one says, all right, we'll have it for everyone with an income over $2,000. You can actually start thinking through, well, what's that actually going to mean in terms of the impact of the credit and that kind of thing. And to that I just mean as an example of what I think the book could help do there. That's not to say that there doesn't have to be a lot of work of organizing and sort of mobilizing in communities on these things to even have a chance to have to vote for candidates that are putting these forward and all those kinds of things. There's a lot of extra stuff there. But I do think the book can be helpful in sort of thinking through what are the policies that we should want and why, if we're trying to improve health for people.
You're listening to the Public Policy Channel of the New Books Network, and we have been speaking with Seth Berkowitz, who's been telling us about his new book, Equal Care: Health Equity, Social Democracy, and the Egalitarian State, new out from Johns Hopkins University Press. That is always a mouthful this year. Thank you, Seth, for joining us. Much appreciated.
Thanks so much. I really enjoyed it.